So good evening, everyone, and thank you very much to AIOS for our invitation to Ransco to speak at the conference in Kochi. I'm just going to be talking about artificial iris implantation techniques. This has been around for some time, but I was quite stubborn to the idea of using this because of the cost involved in using artificial iris, because the artificial iris is quite expensive. It costs about $2,000 for a standard brown one, a standard color one, and a custom made one is about $8,000. So that is roughly about 1 lakh for a standard color and 4 lakhs for a custom made one, comparing the other eye. But it has got its role in reconstruction of eyes after trauma. So this is an artificial iris model, from the Human Optics company in Germany, which is biocompatible, foldable, and it's made of silicone elastomer. And it's got two versions. It's got one with fiber and one without fiber. So the fiber-free one can be used, in the bag or in the sulcus, whilst the one with fiber is more rigid and it's used for scleral fixation. Because I've got quite a few videos, I'll skip the theory and go straight to the videos. So you can implant the artificial iris either in the capsular bag or in the sulcus, or you can also scleral fixate it with Gore-Tex suture, or you can do an iris and IOL complex fixation. So here is a case. This was my first case of iris implantation in a phakic eye with a permanently dilated pupil secondary to injury. And he had a dense cataract. So let me just fast forward the cataract, because I'm sure you all can do a cataract better than I do. Okay, so I'm injecting a capsule tension ring because you want to expand the bag nicely. And here the lens goes in the bag. And here what I'm now going to do is I'm actually going to place the iris prosthesis in the bag on top of the intraocular lens, and that's why you have to stretch the bag with capsule tension ring. So here's the artificial iris being opened up. And this is a standard brown. It worked well because the patient's other eye was also a brown in color. And this is the fiber-free model. It comes in 10 millimeter in diameter. So then what you need to do is use a trephine to measure use the trephine to cut the approximate size to 10 millimeters. And here, because you're placing it in the sulcus or in the bag, and you can actually place it in an injector and fold it. And now you can inject this, and then again I'm visco, expanding the bag. And because the bag's nicely expanded with capsule tension ring, I'm now injecting the iris prosthesis in. And once that is in, you need to do a bimanual approach to actually position this inside the bag. You can either place it in the sulcus or in the bag, but I just chose to put it in the bag this time. And I'm just nudging it to make sure it's absolutely centered. So this is the fiber-free model, and the pupil diameter is fixed at about 3.8 millimeters. So it is convenient for fundus examination and what have you. Okay, now let me go to the next one. So this is a person with all of these are after penetrating eye injuries where they've lost the iris completely. So here, this person had about 3.5 or 4 diopters of astigmatism, and as you can see, the person has total aniridia. So what I've planned to do is I've planned to implant a scleral fixated toric intraocular lens, and at the same time, after that, to implant the artificial iris prosthesis. So I'm now doing vitrectomy to clear out all the vitreous, because the last thing we want is a retinal complication later on. And I'm using 25 gauge trocars. So I've made two points, 1.5 and 3 millimeters from limbus. So 2 sclerotomies radially and then line with each other. And I'm now extending the the corneal wound to about 3.5 millimeters. I'm using an Envista toric lens there, and I'm passing a CV8 Gore-Tex suture through the eyelet in the Envista toric. And this is a nice lens for scleral fixation because it's a hydrophobic lens. So here I'm cutting the haptics off, and I'm externalizing the Gore-Tex sutures. So the Gore-Tex sutures that have passed through each eyelet, I'm externalizing them. And likewise, I'm doing it on the other side. So that I'm actually putting the Gore-Tex sutures on the axis of the steep meridian. And you gently pull on these sutures now, and then it straightens up the lens very nicely. So as I tighten up the sutures, you can see that the lens is well centered, and the toric marker on that lens aligns with the axis marks that we've made. And what we should do is we must take care to actually bury these Gore-Tex sutures inside, because if you leave them outside, they will melt the sclera around it, and they can cause a conjunctival and scleral erosion as well. So now that I've fixated the toric lens, so now I'm going to implant the artificial iris prosthesis on top of the intraocular lens. I'm again measuring the white to white, and I'm taking the 10 millimeter trephine. And whilst trephining, you got to make sure that the trephine doesn't slip, because the trephine is extremely sharp. So what I do is I take a Moorfields forceps and press on top of the trephine so that you get a clean cut. And now I'm passing 2 Gore-Tex sutures through the prosthesis. And you got to make sure that the Gore-Tex sutures have to be passed at least 1 millimeter from the edge, because you don't want it to cheese wire. So I'm marking to make sure that we have at least 1 millimeter from the edge. And this is quite rigid actually. So again, I externalize the Gore-Tex sutures out. And these I've made them, limbal, circumferential around the limbus rather than making them radial, so that then they are tied nicely apart. And all this is at 2 millimeters from the limbus. And this, you can put this in through a 4 millimeter corneal incision. So now I pulled up the sutures. So the only thing is, when you look at it closely, you see these 2 white lines on the brown iris, but I think who cares when the eye is aphakic and it's got such such a bad preoperative outcome, a preoperative state, that this is better than nothing. So then I again tuck the Gore-Tex sutures in, and I'm now using glue to glue up the conjunctiva without any sutures. So this is my next case again. Oh, no, I'll go on to the next one. So this is another case where, again, the eye is completely aphakic, and there's this huge iris defect, and there's just a small ischemic strand of iris across the pupil. And all these patients have had severe penetrating eye injury. So what I'm doing is I'm marking 3 millimeters from the limbus and 3 millimeters on either side of that mark, and I'm making a scleral tunnel. And I'm now putting the vitrectomy ports inside. And I've overshot the time. Is that okay? Sure. Sure. So what I'm now doing is I'm actually implanting the complex of both the micropure physiol lens and the iris at the same time. You know, the lens has eyelets, so I'm actually putting the Gore-Tex suture through the prosthesis, through the iris implant and through the lens on both sides, and I'm going to fixate the whole complex in the sclera. So this is the undersurface. So when I turn it up, because from my previous case, I didn't want those two lines to be seen on the iris. So that's why I put it upside down. And so now I'm just going to put the whole complex in. And that's why I made a scleral tunnel, because it's quite, large. And I again do a 3-1-1 with the Gore-Tex sutures and then tuck them in. So at the end, I tuck all the sutures in and I put glue to close the conjunctiva. In the interest of time, I'll skip through my last video as well. So in fact, artificial iris prostheses have a role to play in reconstruction of post-traumatic eyes, especially in countries like, when you live in a bright country and you have, total aniridia, and there is the glare can be debilitating. So they have a role to play, and there are quite a few techniques. There is another technique where I did a Yamane with this, but in the interest of time, I'll show it later.